okay, it's been a couple hours, let's go C-section right now. And I was, sitting there thinking, Mom didn't want to do it, Dad didn't want to, and it's just that quick, let's go. They don't have time.
Sometimes there's very little dialogue between the patient and the healthcare provider making a decision. Ultimately, there should be, of course, and that's where we, the nurse, can advocate for the patient. We can advocate for them to get more information or different information or whatever. You have to be a pretty seasoned nurse and a skilled, seasoned labor delivery nurse to take on, let's say, the system, but it can be done, and I've seen it done many times, and sometimes successfully and sometimes not, but ultimately it's between the patient and the healthcare provider. And these women obviously were looking for something, most of them were looking for something a little more on the natural side, or at least they wanted to be in control. And I think that's where I tend to lie. I want the woman to have choices. I want us to be able to make a choice. And I also want all of us women to be kind to all of us women. Because if someone else makes a different decision than I would like for us all to respect each other for that. Okay, because there's not one way. There are multiple ways. And it's just like, how do you feed your baby? Commercially prepared formula or breast milk or breastfeeding. It's whatever makes these people happy. That's what it's about, being relatively free. So I think choice is really, really important, and I think that's probably what we have to think about most. So in the reproductive system, the one that's doing most of the work, if not all of it, obviously, during labor and birthing, we have contractions that are coordinated, involuntary, and intermittent. And we looked at last week the parts of the contraction. Do you remember what those were last Thursday? That's right. This is the increment, so IN could be the same as increase or increment. DE, decrement, is when it's going down. And this is the acme, the P, or the nadir. You will see all of those words probably. And remember, contraction frequency is, how do we measure the frequency? From the beginning of one contraction to the beginning of the next contraction. So if this is where this contraction begins, and this is where this one begins, this is the frequency. And what is it from the beginning of this contraction to the end of this contraction?
Duration.
That's the duration. That's right. And remember the other part, the third part, the intensity, is measured in two different ways. But is it measured on the electronic fetal monitor? No. Only if we have a special catheter that's inserted into the uterus that we'll look at later. But only if we have that special catheter. The other way is the old-fashioned way, and that's by palpation. And I would encourage you, if you've never felt a contracting uterus, that when you're in labor, with your patient's permission, palpate their uterine fundus during a contraction. Because it's amazing how hard it gets. It gets as hard as the staple. Now, the way that we do that with palpation, like how do we define how strong it is? What is the intensity? And we use it by saying it's mild, moderate, or severe, and we compare it to what it feels like pushing on different places on our head, okay? So if it's a mild contraction, and what I'm talking about is how far can you stick your finger down into the muscle of the uterus? And you can try this out on yourself by contracting your arm muscle or your leg muscle and try to push into it. You'll be able to go through the fat that's on top of it, but can you push into the muscle? Not when it's contracted. Can you when it's relaxed? Yeah, sure, you can push right into the muscle. So that's what I'm talking about. How far can you indent into the muscle? Normally, if it's mild, we say it's like pushing on your nose, because you can push, right? It gives. It'll push, you can stick in there. And then if it's moderate, it'll be like your chin, because we have a little bit more tissue here than we do here, but not as much as on our nose. So we have a little tissue, and then we hit what? A bone, right. And then when it's severe, we say it feels like our forehead, touching our forehead, because there's skin and then bone. There's no mushy-gushy stuff going on up there on our forehead. So that's kind of how we measure that. Now, we also have changes in the cervix, and if you remember, we have dilatation and effacement, and we'll look at a couple of different ways of visualizing that. This is a representation of what it is to be 1 centimeter dilated, and this is 10 centimeters dilated. This is complete. So when they're 10, you can pass those around and feel of them. And the way we measure is by vaginal exam. So when I go in, I feel around the cervix, and I say, well, I can or cannot get 1 finger in, or I can get 2 fingers. Now we don't, even though this would look like it would be 5 fingers, you're still only using 2. But when you get in and you're doing the vaginal exam, you're feeling like this, side to side, up, and sometimes you go like all the way around and feel. And you kind of have to just learn how to do that. Okay? So you're not going to be tested on your ability to do that. But you will need to know that cervical dilatation occurs in centimeters from 1, well actually from 0, and then 1 to complete, which is 10 centimeters. And that's what will retract around the baby's head and they will deliver. Now another way to see this for dilatation, and you can say dilation, I don't care, but this is a box, and inside is this is a vagina box, okay, so we want to be respectful. Use 2 fingers only and be gentle, and put your fingers in, and you will feel a cervix, and it may or may not be open, and you may or may not feel a fetal head in there. A fetal head feels like, what would you think it would feel like? Smooth and round, okay? So I'm not going to tell you what this is yet, so just everyone take a feel. When it's going all around, then we can compare, but don't say out loud what you think it is, because if you do that, Madison, then Veronica doesn't really get to guess necessarily. So do it, kind of keep it in your head, and then we'll look. So this is not what a real vagina feels like, because a real vagina doesn't have air inside of it, but there's some air in here, because our real vagina, the tissues are collapsed, the sides of the vagina are collapsed on each other, right? But at least it gives you kind of an idea of what it might feel like. If you don't want to do it, you don't have to. You can just pass it on. If that gives you willies or something. The other thing that I'll pass around are some lifesavers. Because a lifesaver is sort of, as you suck on it, not chew it, but suck on it, what happens to it is kind of what happens to the cervix over time. So when you get the lifesaver, you know, open it, put it in your mouth, and suck on it. And note that in the beginning, it's thick with a tiny little hole. And after sucking on it, it's very thin, and the hole is bigger. The thinning of it is the effacement, okay? That's the effacement. It's getting thinner, and then just pass these around. If you don't want to do it, you don't have to. And then the dilatation, of course, is the hole opening up, okay? Have some more pictures that might help you. We are not going to do in clinical any vaginal exams. It's listed on our contract as students don't do that. Our students don't do that. So somebody made that decision. It wasn't me. So very interesting. Why do we think of these stages are great? I like the pictures. This thing is so old, you can't see the pictures. Well, we'll show them again next week. It really is, it's not doing any pictures. Does anybody know why that is? Nobody knows. Neither do I.
You put it on a slideshow?
Yeah, it was. Something about the picture. Probably because they're stolen. Was it smart enough to figure that out? No. No, it's not. There's some lovely pictures. There's some lovely pictures of fruit, different sizes of fruit, that kind of thing, because we like to compare medical tumors and things like that to fruit, and I guess I'll just have to show it to you next week. Yeah. But hopefully you'll get an idea by looking at the plastic chart going around and by palpating in the box there about what dilatation and effacement looks like. The whole process of labor is all about dilatation and effacement. It's all about opening up the cervix, thinning it out so that the fetus can pass through. Okay? And then, pushing the baby out comes later. But probably, yeah, these are even my pictures probably. Okay. This is not helpful. So let's just talk then for a few minutes about just general labor and the stages and phases of labor. Because those concepts are important without pictures. There are 4 stages of labor. There are 3 phases in the first stage only. Okay? The others are just stages. Thank you. So in the first stage of labor, this is all about dilatation and effacement. We could say and descent. I mean, the fetus does need to descend, because if there's dilatation and effacement but no fetal descent into the pelvis, then that's not normal. Because labor is a process, it's not an event. It's something that changes over time. It starts out with those contractions being far apart, very mild, not lasting very long, to increasing in how long they last, increasing in the intensity, and increasing in the frequency. To the point when they're in the final part of stage 1, then they may have contractions every 2 minutes, lasting for 60 to 90 seconds. So they're not getting much rest in between. Okay? But remember, that can be a particularly dangerous period of time for the mother and for the fetus, because during the contraction, the fetus is not getting that blood flow through the placenta, because it's being 300 to 500 mLs of it are being pushed out into the vascular system for the mom. Okay? So not getting it to the fetus. Normal healthy fetus, normal healthy mom, everything comes out fine. But you never know. So the first phase of the first stage is called the latent phase. The second phase is called the active phase. And this is called transition. In my mind, I have numbers associated with these that may not be the same as in your book. But when I give you a test question, they're going to reflect your book, okay? Because I'll check it, hopefully, before I write it. So look in your book. But here's the trick. You'll know which phase of the first stage that your patient is in, at least theoretically, by how dilated they are, okay? You can also know by how they're acting, usually, although sometimes that's a little misleading, okay? So the latent phase means not much is going on. This phase can last for hours and hours. It's usually the longest phase. It can last for hours. It could even be a couple of days. During this phase, many women will rush to the hospital, but if their bag of waters has not ruptured and their contractions are not 5 minutes apart, they probably should just stay home, because it is a dirty, nasty, germy place, and we're probably going to slap you right in the bed with the monitor up to you, and then you're going to lay there, which is going to do nothing to help your labor progress. So the latent phase can last quite a long time. And again, I don't want to say because your book is different than what my mind has been for 40 years, so just look at your book and it'll tell you what the cervical dilatation is for latency, okay? The next phase is active phase of labor. During this phase of labor, the patient is becoming more needy, more agitated. Generally, if they have not asked for any pain mitigation, methods before, they're asking now. If they've not been using breathing and focusing and other methods, they're probably doing that now. In the latent phase, you might be trying to admit them, and all they're doing is on their phone and on their Facebook trying to post, we're here, we're at the hospital, they're coming, the baby's coming. And they're talking to people, yes, I'm here. Oh, sure, I'll call you right away. No, go ahead and come up. We're almost done now checking in. And you're just trying to get some vital signs and basic history, put your stuff in your computer, and they're like all over the place, okay? I assure you in the active phase, they're not doing that anymore, okay? If they're not anesthetized, they are paying attention now to their body because their contractions are intense and lasting long enough and coming frequently enough that they require attention, okay? So that usually during the active phase, the standard is that they will progress 1 centimeter in dilatation per hour. So that's kind of a gold standard. So, Lynn, you were saying that at a certain point where you were, they're like, well, it's been a couple of hours, let's go ahead and do a C-section.
Yeah, I don't even know.
That's kind of what they're waiting, that's kind of what they're doing. They're saying, this person is in active labor, and they're not progressing in dilatation. Their contractions look like they're in active labor, they're 4 or 5 centimeters, but they've made no progress in the past 2.5 hours. And that's considered not normal. That's just one piece of the information. Fortunately, we don't have to make those decisions as nurses, but it's kind of putting the whole picture together. But that's what they mean. This picture is not looking normal. This labor is not progressing normally. So we're going to go an alternate route, okay? So latent can last a really long time. Once there is a cervical dilatation for active, usually we'll move forward 1 centimeter per hour. That's kind of the standard normal. Transition can often be the shortest but the most miserable period of labor and birthing. And I say that meaning this is an unmedicated woman. Like, let's just say, I hope my daughter-in-law never sees this video, but she got to a point where she wanted to have an epidural, and then after she got it, she was a whole different person. She's like, whoa, what happened to that patient who was here 30 minutes ago? And thankfully we said, she's gone. Now we got a nice person here. She was not in transition, but she needed some help. That's what she needed. So transition is usually when a patient progresses from 8 to 10 centimeters. And we call it the storm of labor. Contractions are coming fast and furious. And remember now, they could have been, an average labor for a prima gravida might be 14 hours, right? So this could be like hour 12 to 14, could be hour 14 to 16. They've had nothing to eat, and they're hangry, maybe, or tired, right? So they're getting tired out. So their emotions are really, really high. They need a lot of support during this period of time. And they could have 10 contractions, and they could go from 8 to 10 and 2 contractions, 10. It could take 30 minutes, it could take an hour. Who knows, but it's usually very quick, okay? Usually does not take a whole 2 hours for transition. This is a period of time when often, if they're really working very hard through the contractions, where they say things that are unkind to the people around them, especially to their partners. You're never going to do this to me again. You're never going to touch me. I'm never having your baby again. They might say ugly things to the nurse. My husband said with my first child, he said I did like a Linda Blair thing, if y'all know what that is. My head turned around because the nurse who's checking me is like right here and he's over here because he's all nosy. It's like, what's going on? What's going on? She said to him, and I'll never forget it, she's in transition. And I said, I know what that means, I'm a nurse. He said, no, you said, I know what that means because I'm a nurse. Don't be talking about me. And I was like, okay, I don't really remember it that way, but apparently that's what I said. So, or how I said it. So this can be a time that's really, really anxious. These women need a lot of support. If they're going through it without labor, without medication, without epidural, then they're going to need you right in their face, or their partner, their birth coach, their doula, their whoever. They need for you to say, here comes another contraction, let's breathe through this. They need that active, not just, honey, here comes another one. You got to breathe with them, talk to them, and say, look at me, focus. Because once they lose focus, the pain takes over their mind, and they're just writhing and screaming in the bed, which is not terribly effective. okay? So we don't want them to do that. So this is the first stage. These are the 3 phases, and it's all about dilatation and effacement. Dilatation going from 0 to 10 centimeters, which is complete. Effacement goes from 0% effaced to 100%. Now, what does that mean in terms of how the cervix really looks? Well, when we come next week, I can show you some nice pictures, but the cervix protrudes down into the vagina at a varying degree, kind of like our noses. All of our cervixes or cervicides or whatever are not all the same length. They can be anywhere from 1.25 inches to 2 inches long. So some are shorter, some are longer. So there's some subjectivity here. Are our fingers the same? No. So if I get one finger in, I might say this person's 1 centimeter dilated. If a physician with big beefy hands comes in, or a man presumably, gets their finger in, they may say 2 because they got big beefy fingers compared to mine. So there is some subjectivity to this. So ideally, the same person, continues doing the checking. And I will tell you, in some facilities, nurses do very few vaginal exams because there are other people in the healthcare team that are doing it. So in a teaching hospital, you'd think they would do more. No, they usually do less because we don't want to be sticking our hands, even if it has a sterile glove, through a non-sterile vagina up into the bag of waters now that's broken and introducing everything from the vagina up there because you can't help but do that. So we want to limit the times we do that, okay? So if we have residents, interns, fellows, they're going to do the checking, those kind of healthcare providers, not the nurses. You'll probably be a labor and delivery nurse doing more vaginal checks in a smaller community hospital because the healthcare providers will not be on site 24/7. They have to be within 30 minutes of getting there. Now some of them cheat, they say, well, I can get there in 30 minutes, but that's only if it's 1 a.m. If it's 1 p.m., it's going to take them 70 minutes. But they cheat like that, seriously, because the hospital will require them, before they give them privileges, to be able to get to the hospital within a period of time, and it's usually 30 minutes. Sometimes they're really farther away, and they just cheat like that, okay? So that's what dilatation and effacement are. Do you have questions about that? What's the second stage? It's delivery of the fetus. That's all about that. This is where we push. By the way, there is still, hold your breath, and count, and somebody's going to count to 10 while you push. That is not recommended by labor and delivery nurses or by the Association of Women Obstetrical and Neonatal Nurses, A1. That's an acronym. I don't know if you're familiar with it, but for those of us that are in this field, neonatal nursing, it's not recommended. Some people don't feel comfortable teaching women how to do the push the way I'm going to show you, or the patients themselves don't feel like doing it because it sounds like they're sitting on the toilet going poop. Now it is kind of the same muscles as those you use to push out stool. It is the perineum, but sometimes here's the trick. They've had an epidural. They don't feel anything. So they're going like this. They're going, and you see that person the next day and all their scleras turn red. They look like some sort of demon. Did they push on their perineum? Heck no, they pushed up here in their head and they burst all the blood vessels in their eyes. So the theme is to probably let some of that numbing wear off so they can at least feel their bottom before they push. But when they do, it's not considered to be the good pushing to do the whole 10. It's called open glottis pushing, and so you make noise. And for some patients and some nurses even, they're uncomfortable with it because it's associated with having a bowel movement, which I don't want to be rude, but we've all done that, hopefully within the last 24 hours. We all are going to do it again in the next 24 hours. In our business, we should get familiar and comfortable with the concept of having bowel movements, okay? So it sounds like, instead of like, it actually makes noise. They go, and push like that. Now try to do that yourself. If not now, later, you don't have to. But if you're doing that, going like that, okay, you can't push up here. releases at one point. And if you're going, I can't go like, oh, it just doesn't work. So it makes you push down there. So that's the advantage of doing it. Okay? But that's all about the delivery of the fetus. Sometimes you'll see when we go to clinical, it'll be one push, poof, baby pops out. Sometimes it might even pop out when we weren't even ready. Or it can be 2 hours of pushing. Now, is there a picture in your book, somebody who has their book of, the doctor, what's the doctor's name? Friedman's curve, Friedman? Friedman, I make that up. Yeah, Friedman's curve. Can somebody look and see, look in your index?
Yes, it's Friedman curve.